That was Martina McBride saying, "I'm gonna love you through it." We have a patient, a guest here. Her name is Marissa Magcawas, who's a stage 2 breast cancer patient. Welcome, Marissa. Thank you for taking the time to wake up early and join us here live in our studio.
Hi there, yes. Good morning, Joseph, and good morning also, Dr. Anderson,
Yes,
and all the listeners of Red
FM.
93.1 FM.
Yes.
Thank you for inviting me.
Oh, you're welcome, Marissa. And we have on the phone here Dr. Benjamin Anderson from the Fred Hutchinson Cancer Research Center. Are you there, Dr. Anderson? Can you hear us?
Yes, I am. I'm also very pleased to be with you this morning.
Thank you. Thank you for waking up early. Let me say that Dr. Benjamin Anderson is the director of the Breast Health Clinic at the Seattle Cancer Care Alliance. He's also a professor of surgery at the University of Washington School of Medicine, and he's the chair and director of the Breast Health Global Initiative at the Fred Hutchinson Cancer Research Center. The Fred Hutchinson Cancer Research Center is located in Seattle, Washington, and it's one of the world's leading cancer research institutes. Dr. Anderson, let's start with you. You are head of the Breast Health Global Initiative. Tell us what's happening with breast cancer, and based on my research, it's the most common cancer among women in developing countries, as well as in low-income countries, and in Canada, actually, it's also number one, excluding non-melanoma skin cancer.
Well, you're quite right. Breast cancer is the most common cancer among women around the globe. And that is, that's, of course, a major problem, it also has given us the opportunity to learn quite a bit about the disease. And so in many countries, high-income countries like the United States, like Canada, many Western European countries, breast cancer mortality has been dropping. The issue is that this has not been the case yet in low- and middle-income countries.
And why is that?
I think that it's because the systems aren't in place to address it. To improve breast cancer outcome, you have to find it at early stages, you have to prove that it's cancer, and you have to treat it appropriately. And the focus of the Breast Health Global Initiative is to determine what we know based on evidence about how to make these systems function in an effective fashion.
And you're saying, you mentioned the first thing that a difference is in the test, in the screening, in the early detection. Here in North America, we have access to mammography, ultrasounds, and other screening tests. Okay, those kinds of tests those kinds of machines are a bit expensive to have in third world countries. Am I right?
You're certainly right that having the equipment to do screening mammography, there's a cost issue there, but it's actually a mistaken concept that what we need to do then is go purchase a large amount of mammography equipment and send it around the world. And the reason I say that actually was what people were doing in the 1990s and early 2000s, and it simply wasn't helping. And that's because to make screening mammography effective, you need to have an infrastructure that's largely not in place. If you go to Latin America, if you go to Africa, the problem is that women present with large advanced cancers that you could feel in the breast. They may have been present for a number of years, the woman not knowing that this growing lump in the breast is a problem. And when you have these very advanced cancers, screening mammography is not the next step. It's actually how do we improve breast awareness, improve the understanding that early cancers can be treated and that we do well. In the United States and in Canada, we cure 4 out of 5 breast cancers. But if you go to Latin America, it's closer to 1 out of 3.
Right.
And in Africa, it's depending on the country that you're in, because the cancers are so advanced and because the systems are largely absent, it is something of a death sentence in many regions.
Are you saying that women have a different attitude and behavior towards having their breast screening in developed countries versus in low-income countries?
Well, no, I'm actually not saying that necessarily. We did a study of the experience of women and from different regions of the world, and found that the fears and the concerns and the worries and the what does this mean to my family, actually that experience is very similar throughout the world. But there are differences in terms of beliefs and in terms of awareness. In many countries, women, when they find a lump, they may not come in for evaluation until it causes them a significant problem. But you know, breast cancer in its early phases is a painless lump in the breast.
Mm-hmm.
And so part of this is an educational issue. In some countries, women believe, and men, that cancer is invariably fatal. And if you believe that, well, why would you come in early for a diagnosis? Because it wouldn't make any sense if you're just going to die anyway. And so the most fundamental aspect is doing what you're doing now, which is providing education to your listeners that, in fact, early cancers are treatable and we get significantly better outcomes, often with using therapies that are less aggressive and less difficult for the woman to go through.
Well, Dr. Anderson, you mentioned the early detection, and we have here Marissa Magcawas, who tell us, Marissa, when did you find out? How, if you don't mind, and you can answer no to any question that I'm going to ask you, if you don't feel comfortable about it. How old are you, if you don't mind, or what's your age group?
I'm actually 50 years old.
50 years old,
Yes.
and do you have any children?
I do. I have a precious son named Tyrell, and he's turning 13 this November 28th.
Okay. And when did you find out? How did you know that you had breast cancer? Did you feel a lump? What was? How did you find out, and when?
For me, it's actually really a shock. And when I turned 40, I was recommended to do annual mammography. And it was just recently that I found out it was March 28th. And I normally do annual mammography, as I've said. And it was really a shock to me. And you just never know, really. And I didn't feel any signs or symptoms at all. And
Until you had a mammography.
yes,
This year.
Yes, and first it was abnormal mammography, so they called me and did it again, and after that, I did an ultrasound.
Yes.
And after that, they were very sure, and then they did a needle biopsy.
I
Yes,
see.
Yes.
Dr. Anderson, Marissa mentioned that she has been undergoing mammography since she was age 40, and now she's turning.
I turned 50 last January.
You turned 50 last January, so you're turning 51
Yes.
next year. So, my question, Dr. Anderson, is that there are studies that indicate, even from the Fred Hutchinson Cancer Research Center, from your colleague, Dr. Connie Lehman, I believe, Constance Lehman, that mammography has a high percentile of negative false reading. That's a negative false reading, or the chances of mammography finding out whether there is a tumor is much lower as opposed to ultrasound, and especially with women 30 to 39 years old, because their breast density is more. Their breast mass is more dense than women older than 39 years old. So in this case, what do you think? Was Marissa, the doctor was sort of like did not ask Marissa to do any ultrasound? Was that reason why she was not aware of it till 50?
Yes, there is a reason that to not use ultrasound in that way. It's important to understand there's a difference between using a test for diagnosis, where you already know you have a finding, like a lump in the breast, and where ultrasound is a very helpful study, versus screening. In screening, you're examining a woman who has no known abnormalities. She's not aware of abnormalities, and the screening test is then to look for cancer. And so what we were talking about earlier is screening mammography. Using ultrasound to just screen the breast
Yes.
has problems, and there is no perfect test. That's why the idea that if we just say mammography saves lives, that it's a soundbite that underrepresents the complexity. So could I ask, ma'am, did you, first of all, age 50 means you're young. In fact, I think life really just gets started around age 50. So I congratulations and welcome to this period. But are you saying that you had noticed a lump in the breast and then came in for the mammogram at age 50, or are you saying that the mammogram first found the cancer at age 50? I didn't quite get that.
Yes, the latter part, doctor. I went to a mammogram. They called me again, apparently abnormal, and they found a lump, and I did ultrasound and a needle biopsy.
Got
I
it.
I never really find any symptoms, but then recalling in the past, I remembered that when I was 18, I had a breast mass operation, and it was benign, of course, at that time.
Why did you have a breast mass operation at 18?
They found a lump. No, I just recall.
That was a benign lump.
Yes.
And by the way, I forgot to ask you, you do have a family history of breast cancer, am I right?
Yes, my sister actually had it when she's at the early age of 40, and it's been like 15 years now, and she's healed.
And would you know whether you have a gene mutation with your BRAC1 or BRAC2? And for our listeners, correct me if I'm wrong, Dr. Anderson, these are genes that promote growth and that restrain growth, rather, of cells, and the mutation thereby increases growth, which can be cancers. Am I saying that right, Dr. Anderson?
So the two genes are called BRCA1 and BRCA2.
Uh-huh.
And actually, BRCA1 was first described by Dr. Mary Claire King, who is at the University of Washington. And those genes are predisposed to breast cancer and also ovarian cancer, and they do tend to show up at younger ages, women in their 40s. However, BRCA1 and BRCA2 only explain about 10% of the breast cancers that we diagnose. And so the fact that you have your sister had breast cancer, that is associated with increased risk, but actually we probably all have a family history of breast cancer if you just knew enough of your relatives, because it is the most common cancer among women. What she said was that she actually didn't feel a lump, and that the mammogram, the one that she got at age 50, was the first mammogram to show it. And so that actually is what screening mammography is supposed to do. It's supposed to find the cancer before you can detect it by examining your own breast or noticing it in the shower.
But
The issue is that even with very aggressive annual screening mammography, that doesn't mean every cancer you find is early. There still are some cancers that will be more advanced. Sometimes they're stage 2 cancers. That's a middle level. And on occasion, you have advanced cancers that don't show up on the mammogram until late. But still, we do know from these large randomized trials that when we use screening mammography, particularly in women 50 and above, there's more controversy about women in the 40s, but that we do make it less likely that women will die from breast cancer. And so that actually, I think you did everything right. What you are describing isn't, you failed in no way. That this is how we find these cancers, and it relates to why breast cancer treatment is so important. It's not just finding the cancer, it's treating it appropriately.
But Dr. Anderson, let me go back to the question of early detection. If mammography is not 100% sure, or even a percentile sure, and ultrasound isn't either, and other tests, that's a little pretty bleak picture for women, especially in their younger age. How can I find out? 90% sure I don't have any lumps, I don't have any symptoms, that I have breast cancer, and should I wait till I have a mammography? And in Marissa's case, she was very diligent in doing her mammography every year, and she found out this year that she's on stage 2.
So when you do screening mammography, around 20 to 30% of those cancers that you find will be at least stage 2. So we don't find every cancer as stage 1, and that's because some of them are node positive, and that has to do more with the biology of the cancer than it does when we find it. The problem with using ultrasound as a screening tool, in the setting that we're talking about, is it has a very high what's called false positive rate. Mm-hmm. False positives mean that when we do the test, we see something that we think might be abnormal, and then you have to do additional studies to show that actually that was